Good evening, EDIC Part 1 aspirants for the debriefing session of Mega Mock Test and our honorable faculty. It would be conducted by Dr. Gunadhar Padhi. He is a senior consultant in critical care medicine at Apollo Hospital, Navi, Mumbai. His area of interest is in ECMO, CRRT, and extracorporeal therapy. Over to you, sir.
Good evening, all. So today we are going to have this mega mock test EDIC 1, and we'll have some A-type questions and J-type questions. So 25 each. So we'll make it in a very interactive session. There is some little bit network issue, so I'm not keeping my video on, but we can interact. And at the end of the talk, actually, we can have some questions or doubt solving session from you. So let's start with the A-type session first. See, this A-type session is basically in EDIC 1, you can have this single answer type of questions, where the answer is usually 1. And you have to actually specifically pinpoint the right answer. And then you will get the mark. Otherwise, if you are answering a wrong answer, you will not get a mark. Probably, I'm not sure whether there is a negative marking or not. Probably the negative marking is not there. So this session, I usually have 5 questions from each different systems, starting from the respiratory to cardiac to your neurology, gastroenterology. So like this. So we will have these type A sessions. So let first start with one of the neurological session. And the questions of this such type A, your group will come like this. Like for example, the question will be asked for Guillain-Barré syndrome. So the answer will be displayed like this, like it affects more females than males. Is a disease of the middle aged. When secondary to a respiratory illness, the majority of the cases present within a month. The presence of cranial nerve signs effectively rules out the diagnosis. And the last answer is the most common associated pathogen is Clostridium perfringens. So normally it is expected that a student of EDIC 1 who appear for the EDIC 1 needs to know everything about the theoretical part of Guillain-Barré syndrome, because it is one of the most common one of the most common disorders sometimes the intensivist encounter. So starting from the incidence, so one question will be on the incidence, one question will be on the sex and age distribution, one question will be on like what is the pre-incidenting events and what are the different factors that precipitate such illness. You maybe get questions from what are the different treatment options, starting from the steroids, what is the evidence, starting from plasmapheresis and like IVIG, which is better, which is not better, and other treatment modalities, also supportive care, when to intubate, what are the criteria for intubation, then what type of paralysis, how to differentiate Guillain-Barré syndrome from other kind of ascending paralysis. So these are the different questions. So if we go to these questions, so let's see what the literature says. So normally in these questions, probably I can answer that mostly it is a illness which precipitated by some kind of viral illness, probably in the gastrointestinal tract. And usually you 5 to 7 days of the gastrointestinal GI infection, and the most common pathogen is a Campylobacter jejuni. So if you see the correct answer is basically the presence of cranial nerve signs effectively rules out the diagnosis. So is it true? So most likely it is not the true. Yeah, so the correct answer is the C. So what is the C answer? Basically, when secondary to respiratory illness, the majority of cases present within a month. Let's see what the literature says. So Guillain-Barré syndrome affects individuals of all ages, although there is a bimodal tendency towards the young adults and the elderly. There is a slight male dominance. Yes. The disease usually affects children with less clinical severity. So mostly it is a disease of the adult. Okay. The majority of the cases of GBS occur within a month of either a respiratory or gastrointestinal. So both are true. So here it is given as a respiratory illness. But most commonly, if the gastrointestinal infection is there, the most common likely causes the infection is a gastrointestinal infection. Usually, these patients have a diarrhea followed by your sudden weakness of ascending weakness of both the lower limb. And the commonest pathogen which is encountered is Campylobacter jejuni. There may be questions like what are the other organisms involved in the Guillain-Barré syndrome? Like there can be a Epstein-Barr virus, there can be Mycoplasma pneumoniae, there can be a cytomegalovirus virus which may cause such type of illness. And very important is this respiratory illness. Usually it is not that common, but it can happen following the respiratory illness. Sometimes this paralysis is ascending one and it can involve the respiratory muscles, and it can cause autonomic dysfunction. This is one of the questions. And patients can also develop your different type of polyneuritis and neuropathic pain like symptoms. You have to go through all the different variants of Guillain-Barré syndrome. What are the different axonal sensory motor neuropathy? What is plain sensory neuropathy? What are the different variants? So, and what are the diagnosis? What are the LP finding? What are albuminocytological dissociation? How do you actually, what are the diagnoses of choice? So most of the times it is a nerve conduction study. Okay, what are the different finding and how do nerve conduction study of GBS varies from that of the myasthenia gravis? So one is the amplitude and second is the latency. So how do both the things vary in both the conditions that you need to remember? So it is a very, very important questions. I can say the favorite questions by the examiner of GBS. And you have to read in a detail everything regarding the GBS. So the next question is regarding the acute management of subarachnoid hemorrhage. So I just request everyone to just read the following choices. And SAH is also a very important topic in critical care medicine. There are a lot of questions which can be asked from the SAH, starting from the CT scan finding, starting from the management point of view, the presentation, transcranial Doppler. You may be given some of the pictures showing the transcranial Doppler images, like the increase in the velocities and Lindegard ratio. So all these things may come in your exam. And what are the different options and what are the different complications day-wise, which is the first complication expected, second complication, third complication, fourth complication. So just go through the different choices, then we'll be discussing this. So in these choices, the first thing is the vasospasm. So normally the incidence of the vasospasm is in the first week, after the first week commonly, and it can happen up to 21 days. There is a famous trial which is called the MASS trial, which is the evidence you need to know. So the evidence says that actually there is no benefit of the intravenous magnesium sulfate for aneurysmal SH. The third choice is hypervolumia, hypertension, and hemoptysis. Of course, now the recent guideline says that it is not the triple therapy, but it is only the hypervolumia and hypertension, which helps to reduce the incidence of vasospasm. Which is the targeted map recommended for such patients? Yeah, I can go for this choice. Probably the target map is more than 90. Normally, before clipping and after clipping. Before clipping, the map should be less than 60, and after clipping, the map should be more than 90. Clipping and coiling are equally effective treatment. So both the things are not actually the effective treatment. It depends on the type of aneurysm. If the aneurysm base is broad, so you can, and the aneurysm is smaller in size, probably in that case, the coiling are better option. Whereas the aneurysm if the base is narrow and the aneurysm itself is bigger in size, probably the clipping involves direct opening of the skull, like craniotomy, and clip the aneurysm. So clipping is a good option. So these are the questions. Normally it will be asked. Yeah, of course, there is other questions, as I told you. So the trial, there are other different trials. I already told you regarding the MASS trial, which suggests no benefit. The triple S therapy is now fading away. and now it has been suggested that it is more harmful than actually beneficial, and the target map, and they sometimes ask you regarding the ICED guidelines, like International Subarachnoid Hemorrhage Trial. The study demonstrated that in patients with ruptured intracranial aneurysm, disability-free survival at 1 year was significantly higher in patients treated with endovascular coiling compared with neurosurgical clipping. That is the reason the evidence is more and more towards the endovascular coiling. Clipping is now restricted to aneurysms that are not amenable to endovascular treatment, like as I discussed, like where your those with wide necks and where the coiling is less effective. You may be asked questions regarding essays from other aspects like transcranial Doppler, OSCEs from transcranial Doppler, Lindegard ratio. Then what are the other complications? The rebleeding within 24 to 48 hours, hydrocephalus within 2 to 3 days. What is the treatment of hydrocephalus? Then your something called as this vasospasm. Then hyponatremia, which is also very common. The cause of hyponatremia is both cerebral salt wasting and SIADH. And also you can also encounter questions like the different other trials, the role of intra-arterial nimodipine, the role of the papaverine, intra-arterial papaverine, then something called a role of IABP, and a role of and you may be asked question regarding the neurogenic pulmonary edema. So these are the different favorite question of SH. How to differentiate CT scan finding of traumatic SH versus aneurysmal SH. That is also one of the MCQs. So just I request all of you to go through the books, and these questions you can encounter in your books and read details about the SH. SH is a very, very favorite topic of the examiner. Next comes the SIADH. So just read about this 5 choices, then we'll discuss. Yeah, so basically hyponatremia is one of the very favorite topic of the examiner, and they want to know you regarding detail regarding every aspect of hyponatremia, starting from pseudo-hyponatremia to true hyponatremia, what are the causes of true hyponatremia, whether it is a euvolumic hyponatremia, hypervolumic, hypovolumic, and what are the different categories, and how to differentiate between true euvolumic versus hypovolumic or hypervolumic, the urinary sodium, the urinary osmolality, and how to differentiate true versus pseudo-hyponatremia by plasma sodium measurement and your calculated osmolality. What are the different osmolar gap? Okay, so if you go through SIDH, is typically it is one of the euvolumic hyponatremia, and normally here we find that the urinary sodium levels are usually on the higher range, more than 100, and urine osmolality. If you see the urine osmolality also in the higher range. So basically the urine osmolality is raised, the urinary sodium is raised, and it is a euvolumic hyponatremia. So most of the SIDH they settle with fluid restriction compared to other hypovolumic hyponatremia and other group of your hyponatremia. So here you need to restrict the fluid, and of course the plasma osmolality is usually on the lower side. Sometimes it may be normal, and the serum osmolality, if you say, there is definitely a hyponatremia, or it is a true hyponatremia. So in SIDS there is a hyponatremia. Sorry, here it is hyponatremia written, but actually it is hyponatremia with fluid retention and increased urinary sodium excretion. The serum osmolality is normal to low, while the urinary osmolality is raised. It is a volume-loaded state, and treatment is fluid restriction. The only way to differentiate from cerebral salt testing is clinically judging the volume status. So the most important thing here is that once you label a patient of SIADH, always you have to rule out the cortisol deficiency and thyroid dysfunction. After that only you can label the patient as SIADH. So in every patient you have to send the TSH and cortisol, and if the cortisol and TSH is normal, then they can be actually fall under the category of SIDH. So here you go and read about the other different causes of hyponatremia, like cerebral salt wasting, or your what is the different, like other things like hyponatremia of congestive heart failure or chronic renal failure. So those are the hypervolumic hyponatremia, and typically the cerebral salt wasting is a hypovolumic hyponatremia. Then other things of hyponatremia like pseudohyponatremia like hyperglycemia, hypertriglyceridemia. These are also the causes where the serum sodium may be low, but actually those are not the true hyponatremia because the plasma osmolality in such cases remains normal. So that is the reason you have to ideally measure the plasma osmolarity, not by calculated method, but by freezing point depression. The serum sodium should be measured with freezing point depression, and that will give you a true value of the serum sodium. So these are the different questions, and they may be asked you regarding the correction of hyponatremia. How to correct hyponatremia? Where the 3% NS is indicated. In symptomatic acute hyponatremia, you have to give 3% NS. Normally, in other forms, when the patient is there is no neurological deficit and the patient is having hyponatremia, if the serum sodium levels are less than 120, probably that case you have to treat with normally normal saline. Okay. So if the serum sodium are very low and the patient is symptomatic, then you give 3% NS. How do you start 3% NS? Normally it is the body weight. Suppose you want to start 3% NS, the patient, and always target a serum sodium rise in a day 5 to 10 milliequivalent, not more than that. Because it's rapid correction of hyponatremia can sometimes precipitate seizures and also cerebral pontine malurinalysis. That is also another danger. So that is the reason of osmotic demyelination syndrome. So these are the favorite questions of regarding the hyponatremia. This is always a very, very important topic. Always go and read about this. Okay, now this fourth question, just read and then we'll discuss. So first type of questions, they can directly come from the guidelines. So you have to read the 2011 BTS guidelines, 2011 BTS asthma guidelines, and you have to see what are the different types of asthma and what are the criteria for the life-threatening asthma. So any person who is having a silent chest, or that patient is considered to be in the impending respiratory failure, and he is considered to be in the life-threatening asthma. So any silent chest in an asthmatic attack is not good, and that is the reason the silent chest is a life-threatening asthma. Whereas these other factors like PaCO2, PaO2, inability to complete sentence in one breath. So either they are all either a moderate severe asthma or a near, you can say the near fatal asthma. Whereas silent chest is always a life-threatening asthma. Okay, so a raised PaCO2 is a sign of near fatal asthma. A peak expiratory flow rate of less than 33% predicted is associated with a life-threatening acute exacerbation. A PaO2 of less than 8 kilopascal is a life-threatening sign according to the guidelines, and age is a silent chest and arrhythmias. So these are the British thoracic guidelines. An inability to complete the shortness in one breath is a sign of acute severe asthma. So you have to know actually what is acute severe asthma and what is near fatal asthma and what are different life-threatening your signs of such asthma as per the BTS guidelines. Very, very important. This is actually a question which is being picked from your EDIC, your MCQ model, and those are the straightforward questions. So never to miss such straightforward questions. So you can be last lot of such guidelines like COPD guidelines, gold criteria, like your different your pulmonary infection CPIA score. Those are the straightforward questions, and you should not miss it. Now, question number 5. So this type of question is basically being asked. You will be giving a scenario, a clinical scenario, then followed by you have to evaluate the patient and whether you have to see as per the different criteria to which category the patient belongs. Okay, and what is exactly the clinical syndromes happening with this patient. So like here it is given a 77-year-old male admitted to the ICU following emergency repair of the ruptured abdominal aortic aneurysm. But during the operation, he received 10 units of blood transfusion and was transferred to ICU, intubated and ventilated, initially with minimal oxygen requirement. 24 hours later, his oxygen requirement has begun to increase. His PF ratio is 28.3 kilopascal. That is very low actually. And his chest X-ray shows new bibasal interstitial shadowing. An echocardiogram demonstrates good right ventricular and left ventricular function with ejection fraction of 55%. His stroke volume variation is 14%. So the most likely diagnosis. So he is an elder person. He has a road traffic accident. He has a major abdominal aortic aneurysm rupture. He has been operated, then received multiple transfusion, almost 10 units. You can say it is a massive transfusion. He came to the ICU, intubated, ventilated, and after 24 hours. So all these events has happened after 24 hours. For 24 hours, his oxygen requirement was good. After 24 hours, his oxygen requirement started deteriorating, and his X-ray shows some bivessel interstitial thickening. The second part is the echocardiogram, which shows that his EF is good, his stroke volume is good. That completely rule out the cardiac part. That means the cardiac part is, from echo-wise, is good. So it is primarily you are dealing with a respiratory problem. So the most likely diagnosis is acute lung injury, ARDS, ventilator-associated pneumonia, transfusion-related lung injury, and cardiogenic pulmonary edema. So let's go one by one. So the first thing is this acute lung injury and transfusion-related acute lung injury. So if you see, the transfusion-associated acute lung injury basically happens within 6 to 8 hours of the massive transfusion. But this patient is actually developed the symptoms after 24 hours. So here the timeline is very, very vital. The cardiogenic pulmonary edema, this is not a cardiogenic pulmonary edema, since you can say that the X-ray is almost filled with fluids. You can see bivessel interstitial shadowing, which is suggestive of fluid. But the echo is normal. That means that rule out cardiogenic pulmonary edema. So even if this is a pulmonary edema kind of picture, but the echo is normal. So it is not cardiogenic pulmonary edema. Ventilator-associated pneumonia, this patient is not being ventilated for more than 24 hours, not 48 hours. So the ventilator-associated pneumonia choice is out. Probably it is a ARDS or acute lung injury. So in the recent guidelines of Berlin definition, you find that acute lung injury and ARDS, both are synonymous. So they are not different. But the better option here is always go for the best option, is acute respiratory distress syndrome. So within 24 hours to 7 days, where the cardiac functions are normal, there is a precipitating cause, and you will find the PF ratio less than 300, and the chest X-ray is worsening. There is a bivessel interstitial thickening. The same thing what I was telling you is being written in Berlin definition, and he has classified the trolley versus VAC. So these are all clinical, the point where you have to definitely look into, and you have to see where this option is more fitting and this option is not actually fitting. That is what. So it is a purely clinical questions. Okay. So such questions may be asked, like they may be given as situations. They may try to ask you regarding a syndrome, try to ask you regarding some of the clinical scenarios, try to make you or try to ask question regarding what is the best intervention, what is the earliest intervention. All those things may be the questions from the A type in your studies.